Scott County, providing safe, healthy, and livable communities.
We're on to 6.1, which is to receive information on Scott County Delivers topic, helping those with disabilities live healthy and well in the community.
Good morning, Mr. Chairman. Good morning, Commissioners. Thank you for some time to talk with you today about serving our most vulnerable residents. This is a really important responsibility of government. The citizens recognized that when they drafted our results maps, and certainly our current strategic plan recognizes the importance of having services accessible to people to help them live as independently as possible. So we're going to talk today about whether anyone is better off as a result of these services. And we have a panel of folks here today to talk with us about that. I'm going to ask them to introduce themselves, but first, Steve is my co-facilitator this morning. Steve, would you just introduce yourself, please?
Hi, I'm Steve Jones. I'm a principal financial analyst in OMB.
Thanks, Steve. Thanks for helping me today. And then I'm just going to go down the line of presenters and ask each of you to identify yourselves and the role that you play in serving our vulnerable populations. Danielle.
Hey, good morning, everybody. I'm Danielle Fox, the Adult Social Services Manager here at Scott County.
Good morning, Shona.
Good morning. My name is Shona Biskins. I'm with the Home and Community Care Unit, and I supervise the Men's Choices team.
Good morning, Lori.
I am Lori Reller, and I supervise the Adult Mental Health Unit, which includes case management, pre-petition screening, and our Anchor Center, which is our community support program.
Morning, Lori. Jeff?
Hi, I'm Jeff Daker, and I supervise the transition and adult-aged individuals with developmental disabilities.
Morning, Jeff. Brittany?
Good morning. My name is Brittany Bussey. I supervise the adult protection team as well as some of our internal case managers.
Morning, Katie.
Hi, I'm Katie Elleros. I supervise the Children's Developmental Disabilities Unit as well as all of our contracted case management vendors.
Morning, Katie. Jody.
Good morning. I'm Jody Kieser-Kisting from the Scott County Attorney's Office, and our office partners with Human Services and law enforcement in order to advise and in some cases bring court actions to help vulnerable adults and other individuals in the community that need services and may not want to obtain them always voluntarily.
Morning, Jody. Thank you for being here. Alan.
Good morning. I'm Alan Hermann. I am supervisor of SmartLink Mobility Management, which basically supervises also the TransitLink contract and also the non-emergency medical transportation coordination.
Perfect. Thanks. Thanks for being here, Alan. Peter.
Good morning. My name is Peter Goldstein. I work as one of the housing coordinators with Scott County. I provide support across HHS to any number of the clients receiving services, as well as citizens unconnected to supports who are experiencing housing instability.
Thanks. Good morning, Peter. Tamara.
Chris Tamara Siebertson was actually unable today, but had worked with us on pulling together materials and looks forward to data back. She is from St. Francis Regional Medical Center.
Okay, thanks. Felicia?
Hi, everyone. I'm Felicia Young. I am a regional resource specialist with the Department of Human Services in our Disability Services Division, and we provide support to lead agencies regarding DHS policies and practices. Thank you.
Thanks for being with us. And Molly?
Hi, I'm Molly Link. I'm the Assistant Housing Director with Scott County CDA. Scott County CDA owns 238 project-based units and oversees the Section 8 program with over 600 vouchers, that nearly 30% of which are disabled and receiving disability benefits. We actually have senior and disabled units, about 40 of them, that are specific to that. And we have vouchers that are where we partner with Scott County Human Services that are focused on people that are struggling with mental health issues.
Thanks for being with us today, Molly. All right, so Steve and I'd like to start by asking a few questions. JJ, I will share my screen, but I don't think it's sharing right now.
Chris, would you mind if while you're pulling that up, I just give us a brief introduction?
Yeah, that'd be fine, Danielle.
Okay, so today we have quite a broad focus of work. There are a lot of services, and so we try to sort of package it in a way that was easy to understand. But there's a lot of intricate pieces to this. So today we're talking about eligibility assessments, case management. We're talking about some crisis services for individuals with disabilities, like our residential crisis facilities and commitments, as well as adult protection and there is abuse or maltreatment present. And you'll see a couple of themes throughout this information. There are some successes to celebrate. We've had some technology advancements. We've seen some wait lists be able to be worked through as we've had sort of some saved time with COVID-19 from driving, where we typically were going out to see people. And I think we've seen quite a lot of partnerships strengthen. It takes a lot of different partners to do this work effectively. And I think we've seen them come together like we haven't in the past. And I think we've also seen some challenges. You'll see some themes of some workforce shortages in our work. You'll see challenges with housing and employment for individuals, a general growth and need. And I think we've got a great panel, so I just thank everybody for being here with us today.
Great, thank you for that, Danielle. Let's start. The point of our conversation today is really to talk about access to services and how we help support people to live as independently and safely as possible. So I want to start on this slide, which looks at the proportion of the population per one mental health professional. Much of our data, commissioners, related to health community indicators has not been updated, presumably because of the work that's being done around data collection and analysis for the pandemic. This is a slide that has been updated in it. I just wanted to start here. Danielle mentioned that mental health is one of the populations of people for whom we provide services as vulnerable residents. This slide looks at the proportion of the population per one mental health professional. And I think I wanted to start here just because this is a little bit encouraging. As you can see, looking at the data, the access to mental health professionals appears to be improving. There are fewer residents per provider. And what is equally as interesting, I think, is that this purple line looks at the number of mental health providers across the county. The green, and that is like slowly ticking up, right? The green line looks at how many of those who are mental health providers in our community are employees of Scott County. And that line is gradually ticking down. And so we're in this kind of desirable place of growing a mental health resources in our community that are not exclusively tied to the county. And so I just wanted to start with that because in some of our planning and some of our previous discussions, there was some misunderstanding about that data. So I just wanted to be clear about what that community indicator means. Okay. Steve, did you have questions about the first couple of slides? Otherwise, I'm going to move on to min choices.
Yeah, since you're on this slide, I do have a question here where it's showing Scott County having 1,010 or population per professional. The state's down to 370 population to one professional. I was just wondering, what do you see as a target for the county? There's a pretty significant difference between the 1,010 and that 370 number. And I was just wondering, do we have our own target? And how does the state, how is that number at 370? And if we do have a different target, what would it take us to get to that target?
Steve, I think that's a good question. I think really our target is more about ensuring that all populations have access to them than a number of people. I think we've seen some growth and opportunities through telehealth, for example, where we wouldn't necessarily have to have all of those provided in Scott County to people access services. So I improvement, which I think, as Chris indicated, is shown here, but we don't have a specific target number in mind.
Okay.
All right, let's talk about bin choices. So, Shona, can you just say at a very high level, why is timely min choices assessments? Why does that matter? Why is it important?
Well, number one, it's because, first of all, in statute, it says for initial assessments that we're supposed to get out into the community to see people within 20 days. And for reassessments, we get out there before their services lapse to make sure that the providers are getting paid and that the individuals do not see a lapse in any of their services. Without getting out there in a timely manner, individuals go without services. They have no way of helping to pay for home care that comes in. They have no way of accessing or even knowing what's out there. And so with us being able to get out there in the timely manner, we hopefully can help diminish, if not eliminate, some of the hardships that the individual and or their families may be going through.
Okay, and when you look at this data, how do you use this data on your team to impact the work, given the importance of those timely assessments?
Sure. First of all, we have to look at, are there changes that we need to make within our team to make sure that we can get those assessments out there? Last year or the year before, we implemented some productivity guidelines because we weren't doing well in meeting our goals and expectations around the number of assessments that each individual should be doing, not just based on what they feel that they are capable of doing. We looked at what other counties are doing to make sure that we were aligning correctly with some of the things that they were doing. And when we see that we're not getting assessments done on time, we have to take a step back and ask ourselves why. What's happening? Do we have more assessments that are needing to be done? Is it due to staffing shortages? And, most of the time, it's because we're seeing an increase in the number of assessments that we need to get completed.
Great, thank you. The spike in 2018.
Mm-hmm.
Do you know what would have contributed to that spike?
And why we were getting them completed? Yes. In 2017, the county board approved 2 new positions for us, okay, which meant then that our initial assessors could get out to the community and get those assessments completed, where when we don't have enough assessors and we are seeing our annual assessments needing to get completed, we have to pull them into doing reassessments, or annual assessments is what they're called, to make sure people don't see that lapse in service or payments.
Okay. And then, Steve, did I interrupt you?
Oh.
All right. And then, shoot, I just lost my question. Steve, do you have more questions about min choices?
Well, with going along that same direction with the big increase in 2018, there is a big shift then in 2019, and then coming back again in 2020 and 2021. With the increase of the 2 FTEs in 2018, what was the main driver for 2019 then? And
sure, we had 2 people out on family leave, and we are not able just to, like case management, you can contract out. We can't do that. So we had to really focus on getting those annual assessments completed. And in 2019, we also, lead agencies needed to assume the responsibility for completing the PCA assessments from the PMAPs and the MCOs. So that increased our numbers. And if you look at the reassessments, you'll see that on average, we're climbing about needing to do 130 to 140 additional reassessments than we have the previous year. So we need to move staff over to help in those areas as well.
I may be looking at this correctly, but I see 2018 as being, according to this chart, the lowest number of assessments of any year, any full year. So it tells me, I guess the way I look at this, maybe I'm wrong, is that you just had less people to assess. You didn't actually do more assessments according to this chart.
Well, if you look at the reassessments though, as well, in 2018, we did 1,064 total assessments.
Okay.
Where the previous year, we only did 1,501. That was 100 extra assessments that this team needed to do.
Sure.
Had a huge backlog. And that's why the county board approved our 2 additional positions.
Okay.
Yeah, Commissioner, if you look at sort of the new assessments are the people who are first coming into our system for the first time. So they have an initial assessment with us, and then every year thereafter, they get added to this reassessment or that second pool. So it sort of is a growing volume over time based on the new people that are coming in through the door, but also those that were assessed in previous years.
Okay, thank you. Keep going.
Thank you. Okay.
Commissioner Brecky has a question.
Commissioner Brecky.
Thank you. Shona, can you just give us a general perspective about, as we're seeing increases each year in these assessments, how many are more of our elderly population and how many are adults with disabilities who aren't elderly? Just in my work, I'm seeing so many more elderly people having to apply for long-term care services, and just wondering if you can get some perspective on that.
You know, it's really hard for me to talk about the over 65 population unless they're the AC program, because many of our elderly waiver individuals, they're on medical assistance and they are assigned to a managed care organization who then is responsible for completing their assessments. So we don't even see those individuals. What we primarily see are the individuals that are opening to one of our disability waivers, and that may be our CADI, brain injury. Our CAC numbers, which are hospital level of care, I think have increased, and Brittany can probably share more with you about that than what we've probably seen in previous years. And we've also seen a huge increase in our developmental disability waiver individuals as well.
Thank you, that's really helpful.
Thanks for the question, Commissioner.
Yeah, Commissioner, I think if you also tie that to page number 11, that talks about the number of cases in case management that we've seen come in through the door. So this is sort of all of those cases that end up on one of those disability waiver case management services, which just, I think, demonstrates sort of that overall growth over time.
All right, Shona, as people leave your team, they move on to a case manager. This is data that reflects the customer, the client satisfaction with case management in home and community care, correct?
That would be Brittany's slide.
You are correct, Chris.
Management team.
Okay, thanks. And so I was really excited to see this data actually, because historically, we have measured customer satisfaction just with county case managers. And so bringing in these contracted providers, I thought was really a nice improvement in your data. How are your teams using this information to improve contract management?
And I can let Katie Elleraz speak to that since she covers our contracted area.
All right, so one of the things that we have done with contracted case management and some of the things that we use this data for is to help us pinpoint areas where maybe contracted case management needs some further information or some further training. The survey that we get this information from, there's also a couple of key points where clients can point out areas that they see as areas of improvement. And then based on that information, we might tailor some of our resources that we provide to contracted case management or some of the trainings that we provide to contracted case management to help better meet that need and fill that gap area.
Can anyone speak to why county case management is rated higher than the contract providers?
And the data that you're seeing really, it covers areas that that I supervise or oversee, that Katie oversees, and also that Jeff oversees. So this is a big pool of data that's compiled into one. But from my perspective, I would say overall, if we're looking at Scott County case managers, generally these are people that have been with us for quite a long time. So they have more experience, and I would say that would point to why they are generally rated higher than contracted case managers who oftentimes are brand new.
Chris, I would also just add to that, what's important in this slide is that Scott County is contracting out cases, but we do that in a strategic way. And so if there is a case that is a really high needs case, or there's a case that we're not being reimbursed for some reason, we hold those internally intentionally so that we can assign those more experienced case managers to that work.
Thank you. Steve, do you have any other questions about this before we move on?
I had one question on this one. Just looking from 2019 to 2020, I wanted to say congratulations on excellent going from 63% to the 69.3%. And I think it's a really great achievement considering this is through the COVID environment at the time. So I was wondering, what kind of changes did you make in your business to get through COVID, and how much of that will continue into the future?
That's a great question. I mean, through the pandemic, the state of Minnesota has allowed us to do all of our work remote. So we've been able to interact with the people that we're serving through platforms like this. So we have virtual meetings or phone calls. What I'm hearing from case managers is that we've been able to have interactions with people more frequently because we've reduced our travel time. We're not driving out to see people for every visit. And so it's really given us the opportunity to focus more on those interactions than traveling. I don't know, Katie or Jeff, if you have other things you'd like to add to that.
I was just going to make the same point, Brittany. I think that loss of drive time has allowed people the extra time then to just do some more check-ins with folks. That is something that we certainly stressed, particularly in the Children's Developmental Disabilities unit and for our contracted vendors where children are involved, making sure you're touching base with those parents. We know parents have been extraordinarily stressed during COVID, especially during those e-learning times, and having that social worker, that case manager reaching out to a parent saying, are you doing okay? Do you need community resources, particularly some families who might be struggling with food or having access to healthcare as we've gone through the pandemic? And having that extra touch base, I think, has been pivotal in our work for families.
Yeah, I would echo all those comments too. I think our experienced and dedicated case managers have been able to show their qualities, and the building of those relationships over time and continuing to build those relationships during COVID has really allowed them to demonstrate their abilities even more, and build those relationships with the people most in need during this time. And there are many of those persons. So it's a kudos to our excellent case managers and long-term case managers.
These guys are absolutely right. We saw our staff and our contracted staff step up like they have never had to before. We saw people lose caregivers with COVID. We saw them lose housing. We saw them lose jobs. And so they had to lean on those case managers probably more than they ever had in the past. And we really saw people step up. The other thing I would add to that doesn't reach the human connection, I think, that impacts the score, but we also implemented a new document management system at Scott County, which our contracted partners are part of. So it's our staff to send out, share, and to learn from the documentation that they have.
Are there any downsides in the quality of the visits if they're remote, or are you using some combination of in-home and remote visits, or what's your thought about that?
Right now we're offering choice. So we are doing a combination or a hybrid of in-person and remote visits. And I expect that will continue to ebb and flow as the course of the pandemic continues to change. Speaking from an adult protection perspective, I think, some of the downsides are case managers aren't in people's homes observing what the situation is. And so a case manager is just taking things based on what the person has said. And what we're finding as case managers are getting back into people's homes, situations might look a little bit different than they've been presented before. And so adult protection maybe have more interaction at this point once it's identified that there are families and situations where protection is needed.
Great. Thanks. I wanted to go over here to this crisis bed data. I'm not sure who the best person is to speak to this, but clearly seen a jump this year from 2020 to 2021 in the number of crisis bed days. And I'm wondering if that represents, are all of these people really in crisis, or are some of them in these crisis beds waiting to move to a different kind of setting? Or does this represent crisis?
You would be right in that it's a combination there.
Okay.
You have kiddos who are sitting in crisis and who are truly in crisis and need some stabilization and cannot be in the family home at that time. But you also have kiddos who might be at crisis because we're waiting for a placement to open up for them, or we're waiting for them to be able to return to mom and dad's home, and we're maybe making some home modifications to be able to do that safely.
Okay.
I would add to that too. I'm a Metro Steering Committee member of the 7-county metro area for the residential residential respite stays of individuals with developmental disabilities. And one of the key factors right now of those persons remaining in the crisis residential respite homes is the difficulty in finding suitable providers out there to serve them when they would be able to leave, when they'd be eligible to leave the respite placement. And if they're not able to return home, whether it's a child or an adult, they move into a permanent residential placement oftentimes to get their needs met. And what is happening is many providers now are having difficulty hiring competent staff. It's a part of the staffing shortage, the employment, the provider and employer shortage of hiring competent and trained employees. Wages are having to increase drastically to hire those persons. Less applicants, those types of things, less qualified applicants. And it's creating an incredible strain on the providers that remain to be able to serve persons in a residential placement. So there is fewer providers able to do that. We see providers closing homes because of inability to hire staff. And those that do have homes open don't have as many staff and as many competent staff, so aren't able to take in new referrals from what they already have residing in those homes. So it does make a very difficult time for individuals to move on from that crisis residential respite stay after they're stabilized to be able to return sometimes to their family's home because of shortage staffing there. And as I was saying, to a residential placement because of those difficulties.
Oh, go ahead.
Oh, I was just going to say, to add to Jeff's point, the staffing crisis that we are seeing professionally within what you would traditionally think of as a group home, it's the height I've never seen before in 17 years working in case management. I've never seen a staffing crisis like this. We have providers who are offering $75 an hour for group home staff and are still not getting applicants.
And we've seen, I think, a bottleneck in some of our crisis services, but I don't want that to set the precedence of people thinking that, this is just where we put people where we're waiting, because the threshold to get into one of these beds is pretty high. And I think it impacts that staff impacts our ability to move people on, but it also impacts how many people we're seeing in crisis. If people don't have stability at their residential program or in their own home with their family, they've lost employment services, they don't have those supports in place, or they're provided by many different people, that consistency, we see more people going into crisis overall. So it's sort of, unfortunately, on both sides of that.
Okay, thank you.
Can somebody address the question in chat there?
That was me. It just seemed easier than trying to interrupt again. On this slide, we're looking at bed days, and I just wondered, because I'm sure there's some years with some individual with, there's the tough condition who uses a lot of those bed days. What are we seeing as the average number of individuals versus the bed days?
I think this is Jeff Daker. I think the waiting lists for individuals to have placed in one of those these crisis respite homes is pretty stable for the most part, from what I've been hearing. It fluctuates up and down, even over the last couple of years. But what happens is if the people that are in there are not able to leave, then the waiting list accumulate and increases drastically. Then you have a person move out, or a person or two move out, and that frees up those beds. And there's that revolving door that is what the system is intended to occur. I don't want to call them placements because they are respite stays. The original intent of the system was a maximum of 45 days. There are people there, there's a few, but that have been in there for a year or so or longer in those respite placements. So the waiting list does go up and down. I would say it's elevated a bit. So that's the best way for me to accurately answer your question.
And we can certainly report back on the number of people per year. We have access to data. I think, to Jeff's point, it really varies. We have people that can go to a crisis placement for a short period of time, and we can make some modifications at home or at the residential service provider, and we can get them back pretty quickly. We have others that have extremely, so sometimes we have to recruit a provider, someone who's willing to work with us. They sometimes have to purchase a home, then they have to make modifications to that home. And those, I think, are those cases where we're seeing people sit in there for far longer than we ever anticipated within the, and longer than they should, frankly.
Yeah, I just think that would be helpful to know, like, obviously somebody could use a big percentage of these days in a year, and we could be talking about a handful of people, or we could be talking about hundreds of people, and I think that's illustrative.
Great, thanks. Just one more question before we leave this topic, and that is, this doesn't, I think Danielle used the phrase the bottleneck. Doesn't sound like a bottleneck that county is going to resolve on their own. Are there regional or state initiatives to try to resolve this?
I was going to mention it before your question also, but this question is a perfect opportunity. One of the things that I see that has really been helpful is various counties in the metro area and our county as well. We have developed respite homes for people to have a respite stay before they get into crisis. In our county, we are developing a children's crisis respite home with a woman who had sought us out and asked about this opportunity through a Facebook group she was in. She heard that there was a need for it, and there is a tremendous need for caregivers to be able to have a break before a person becomes, very difficult to manage, where they no longer can be in the home and have to go to a crisis respite stay, to have a scheduled respite stay ahead of time. And I've seen our county, along with other counties in the metro area, there has been more and more of the respite homes starting to open, where it can be a scheduled basis, where it can be a fun stay. It can be activities and supervision and a break for the caregiver. So I see that as something that is occurring. Other than that, there's not a lot of answers right now that I know of. Maybe Katie can expand upon that.
Yeah, Chris, I think these guys have been extremely creative to try to impact this as much as we possibly can as a county. I wonder if Felicia wants to weigh in sort of on her perspective of what she's seeing across the state. Maybe not specific just to crisis beds, but just generally speaking, I think she would have good insight.
Well, I guess if I could, Felicia, I'd love to hear from you. I'd like to narrow that question a little bit though. Like, is there work at the state level to address the bottleneck in crisis beds?
We do have some work groups that are working on this specifically. I don't have access to direct information on this to speak to, however, because we do have some specialized work groups that really are taking that data and looking at this specifically. But I could certainly get them in touch with Danielle to get that information for you.
Oh, nice offer. Thank you. All right. Let's move on to adult protection. And this is kind of impressive data. I'm wondering if somebody could talk through the high points of this data for us.
Sure, I can speak to this. And since this slide was prepared, we actually got our, 2020 data is on there when we reached 100%. So what this slide is showing is that of the investigations that we have completed and have resolved, how many of those we have not come back again in 6 months. So it's a little bit hard to articulate, but essentially what it's showing for 2020 is that 100% of the people that we worked with, they did not come back again with another maltreatment need that we had to investigate. So the state threshold is 80%. Not to get too far into the weeds, but sometimes we deal with people that they're just struggling to take care of themselves. The allegation might be called self-neglect. And, the threshold is 80% because people have the right to make their own choices for themselves. And so even if we're working with someone who may be self-neglecting, it is their choice how they want to live their life. So sometimes those cases may come back again, which is why the threshold is set at 80%. But what you can see is that of the data that we have in front of us, Scott County has far exceeded the threshold for meeting people's needs and not having them need to come back through and receive services through adult protection again.
Nice, well done. Steve, I want to talk a little bit about this slide too, but do you have questions about adult protection?
Not at this point. After we talk about this slide, I can answer them.
Okay. Brittany, there's a big uptick here in 2018. What are your thoughts about that?
Well, I mean, the slide that we're looking at is the allegations that were reported. And so it's a little bit hard to speak to a huge uptick because what we're not showing here is how many reports, because one report could include multiple allegations. Okay. So it doesn't give a good story that way.
Okay, thank you. All right, Steve, adult protection questions?
Again, looking at this graph, I know in the why does this matter? Showing a decrease in allegations reported doesn't necessarily mean it's an improvement. You have it listed that reporting may just not have occurred, but it's a dramatic change from 2013 through 2018. You were always on an uptick, and then 2019, 20, and 21 is dramatically below that. Are you aware of any general changes in the environment at all that have occurred? Or has reporting changed in any manner?
I can only speculate. I'm not aware of anything specific, but I would speculate that the pandemic has something to do with reporting numbers. Again, that's only going to speak to 2020 and 2021, but people were, especially our elderly and those with disabilities, were far more isolated during this pandemic time. They weren't getting out, people aren't seeing them, and so there were fewer reports. I don't know if Danielle or if anybody else would have any other information that might speak to the change in trend. That's what I can offer at this point.
This, I think, Steve, is worrying for us. I think we had seen that uptick of allegation reports coming in, and to us that identified a community increase in need. And so when we saw that drop off in 2019, I think we knew that in 2018 there was some work by the state to do some community awareness. And so there was an ad campaign and some work out there to get the reporting number and things out. People could use it. And I think Brittany's absolutely right. I think that concern about having inconsistent caregivers for folks or not having the same level of services has impacted our ability or not our ability, but our community reporting.
Commissioner Weckman-Brecky.
Yeah, hi, and just to add on to Danielle's comment there, I think during that period of time, communities did more outreach on this too. I know if we look at the financial exploitation there, all of our local police departments did seminars and things with the elderly. There was a lot of additional community work on this. So I'm assuming there's some pandemic relations, there's some just community working on this. But I did have a question for those of you who are working in this closely. Are we seeing, and if we look at just the whole, back to 2013, the whole number of people, is it increasingly the elderly in this pool? That's kind of the perception out there, or is it not? That would be my question.
I don't know that I have data that's accessible to speak to that. That's hard to speak to. If it's elderly people that we are seeing, certainly when we get reports of scams and those financial exploitation cases, primarily those are our elderly population, but across the board, I mean, we're dealing with anyone that's over the age of 18 that has a disability or is elderly. So to suggest it's more elderly than anything else, I'm not sure that I can speak to that without looking at the numbers.
Well, I think that would be some good information to look at, because we do outreach and do the kind of preventive work here that we're doing in other areas to try and prevent this. I think it would be good to know, if there are some trends or changes in the adults in our community who are being, have these issues.
So Brittany, these are actually reported. How many of them come to fruition? This is when you explore it or look into it, it wasn't an issue where the client was okay.
I don't know that I fully heard your question. Are you asking, of those that we're investigating, how many have we substantiated? Is that your question?
Yeah, thanks, Brittany. That is exactly it.
Sure. Again, I could easily pull that information for you, but I don't want to give you the wrong information. So why don't I get that to you at a later time?
We do know that, the number of, I think, substantiated investigations is important, but also just the number of calls that we receive based on the percentage of those that we respond to with an investigation. So I think we looked at data recently, and Brittany, wasn't it between like 10 to 12% of the calls we're actually pursuing for an investigation based on the eligibility of the person and the situation?
That is true. So approximately 12% of all the reports that we receive, we're investigating. But I would also add, additionally, we are responding to approximately 20% of all of the reports through an adult service response, a more proactive response. So through an investigation or our adult service response, we are touching about 20% of all of the reports that we receive.
I would also like to add, this is Jeff Dacre again. I think the comments about it directly related to the pandemic is very valid. I mean, I think many people that that we serve out of the transition and adult age unit, there's less staff, there's less eyes on them in the home. So less staff means less eyes in the home to be able to make reports if there's something going on. Those individuals also may be home from day programs and employment programs beginning during this time. So you may have, you no longer have the eyes of their employers or their day programs be able to hear or see something that would be reportable because those people are remaining at home and there's less eyes on them. I think it's pretty valid probably to say that it's related to the pandemic in many ways.
All right, thank you, everyone. Let's move to the pre-petition screenings. This data shows an increase in the number of pre-petition screenings and an increase in the percent of those that have more than one screening within 12 months. And so what I'm wondering is, are we seeing themes in these cases that would help us understand the increases? The increase in pre-petition screenings is like, that's sort of alarming at a community level. And so are we seeing themes in these cases? Are they different than people that you maybe worked with prior to the pandemic? Or what can you tell us about the people involved in this data?
Well, pre-petition screening really is clients that are at the most extreme and really need court intervention to get the help they need. We see a lot more clients coming in that are very ill in the community. It's been slowly kind of growing over time. I know we go back a few years here, but if you went back 10 years, we really served far less clients 10 years ago than we are now. I don't know if that's just because there's more clients and the percentage of them are ill. We hopefully get people hooked up with good community services to stop repeat, where they would come back through and need another commitment in a period of time. But there's some factors that contribute to that as well. Clients, after maybe a 6-month commitment and are no longer under commitment, are able to be back on their own and possibly could walk medications or not follow through with the supports they were using that helped them after a hospitalization. We see a lot of clients that are just more ill when they're coming into the system. We're also seeing clients that we've never worked with before. Some of our repeat clients are people that we've had. It's a cyclical illness, so that maybe over time, maybe they were committed several years ago, but they're coming back in, or I think this chart actually just shows the 12 months. The clients might need to come back into services if things aren't going well. And of course, like I said, this is kind of the high end of those clients, people that are in the hospital and their doctors are saying they really need to go through the commitment process.
So Lori, as your team looks at this data, or Jody too, I guess I'd be interested in the opinions of both of you. Are there places where services, like understanding people have free choice, right? But are there places where our case planning could be stronger, or where there are gaps or delays in services or court hearings or those kinds of things? Like, are there system issues that contribute to this, in your opinions?
Well, first of all, we're mandated by statute to have very timely court hearings, so we're not really seeing delays on that front. One thing I would note in terms of thematics is that we have seen some individuals that have had anxiety that has been exacerbated by the pandemic and has caused people to not want to go to the doctor because they are fearful of going in for those medication rechecks and those appointments because they don't want to expose themselves to pandemic germs. And so I think something that has been beneficial for other clients that could be beneficial more system-wide would be more access to tele-type appointments, whether it be telehealth, more case management, tele-appointments. I think that might be somewhere that we can show some more benefit to citizens.
Okay. Other gaps or other system issues that might be impacting this?
One thing we don't have in our county is some workers that can go out and do outreach. Sometimes we hear about clients struggling out in the community. Law enforcement, other people are aware of them, but we really don't have any kind of outreach that goes out and works with individuals. Targeted case management really is a different service to serve people that are already in a service. They really need to be wanting. It's a voluntary service unless they've gone through a commitment. And an outreach worker maybe could just be able to work with people that are out there, maybe encourage them to become a client or help them find those services in the community. And that's something that we don't have.
I think that's an excellent point that Lori makes, because we oftentimes receive telephone calls about family members asking if they can have a commitment for a loved one. And we have to make sure that we follow the legal standard. And oftentimes those individuals don't rise to the level of the legal criteria for commitment. But if we had an opportunity to do more outreach, we may be able to intervene earlier on so that ultimately we don't see those people in the commitment system or in needing a crisis hospitalization.
Yeah, I think they hit it on the head. We don't want to see people on this chart. This is when it has gone way too far, and we could have potentially intervened at a number of different points. I think, as Lori mentioned, we would love to have outreach. We would love to have a response when a family member calls and says they're seeing something's wrong. We would love to have someone be able to try to go out and engage with that person. When they have an interaction with law enforcement in the community, when they show up in our jail, just having an alternative place for someone to physically go, like a crisis center. I think we've done a lot to build up resources in Scott County, but there are certainly a lot of potential opportunities that we could expand on before people get to this level of care.
All right, Steve, you have adult protection related questions?
At this time, I don't.
Pre-petition screening, I'm sorry.
No, I don't.
Okay. Then I'd like to go over to here to the transit link slide. And Alan, you recently received a grant for the Hopscotch program, is that right?
That is correct.
And is that with the senior and disabled trips? Is that reflective of that program, or is this different data?
This will be different data. In fact, the Hopscotch program hasn't really transported anyone yet.
Okay.
It's delayed because of basically availability of vans and so forth. So this is really just trips on transit link services.
Okay, but this sets good baseline data for us then as we look at the services provided by Hopscotch.
Correct. So Hopscotch would be meant basically to have that overflow, or in other words, trips that don't fit into transit link. That's where that Hopscotch would come in as a resource to, again, give people options to get around when transit link is not available.
Okay. I'm wondering, just before I turn it back over to Chairman Ulrich, I wonder if you could identify 2 years from now, what kind of change in services or kind of changes in the experiences of our clients would you hope to be able to report back to the board? Like, where are the goals and where are the areas that you're pursuing?
On the transportation side, is that what you're talking about, Chris?
Broader, just everyone. I'm just wondering what the 2-year vision is for how we continue to provide good services to our vulnerable populations.
In the next go ahead. I was just going to say, in the next 2 years, Project Waiver Reimagine will continue to be well underway, if not more implemented than it is now. That is going to streamline services for folks where previously different waivers had different services available to them. There continues to be a huge person-centered focus across the state and here in Scott County. And I think that is something that we're going to just see progress more and more and more and more and more.
Yeah, that I think Peter and Molly are both on and can speak to some of the outcomes with housing. Unfortunately, we've seen an increase in homelessness for individuals with disabilities. There is a slide on here about employment. We are concerned about ensuring that there is enough employment opportunity for people with disabilities, as well as sort of that workforce that goes to support them. I think there are a lot of opportunities for us, but I think that there is a great in Scott County so that we can come together to address those challenges when they come up and when we see them pretty clearly in our data.
In the mental health, I would like to see that we could expand the hours that we have our Anchor Center, which is our community support program, open. This is a lower level of care, so people could either get services when they're just starting to have some issues, or a way to maintain clients in the community. Targeted case management and pre-petition screening are really high-end services. You don't really want to wait till people need that to get them in the door. We really want to try to find a way to have a service that's always available to people during the week.
Anything else?
Can I ask one more question of Danielle with employment? Danielle, you brought up employment. I do have a question with, I saw on page 3 how COVID drastically reduced the employment opportunities for the disabled population. And just looking at the most recent Minnesota DEED numbers, unemployment in Scott County now is down to 2.5%. So there's not a lot of individuals available to work. But when you're out in the community, you see a lot of businesses with signs out that they need help. What kind of, how have we reached out to the business community? Has there been any reach out to the business community about this, potential pool of employment opportunities here?
Yeah, I think there's a lot going on with that. I think with COVID-19, we saw some employment providers for people with disabilities back away from any in-person services or limit their in-person services. And so we saw a big loss of people at facilities similar to like a New Options PRO Act, for example. They kept services going, but had to go remote for a while. So we lost those opportunities. They are, I think, talking to community businesses to try to identify what those opportunities are. We have a team through Guild Incorporated that works, reaches out to employers to place individuals who are served within our adult mental health team. We have New Options and other providers who are out there working with our population of people with developmental disabilities. So I think there is that outreach. I think it is done primarily by our nonprofit service providers and not by county entities, but sometimes we work to sort of connect the dots. So if we hear about opportunities from one side, we can reflect those to our other providers, and they can use those leads to hopefully have success in placement.
I would add to that, Danielle, the Metro Regional Quality Council that I sit in as part of Scott County also has a focus on employment for people living with a disability. And that is a huge part of that council's work, is to connect employers with this employment pool and help them understand the process of WIOA, which is a federal act that looks at getting people who are living with a disability employment opportunities.
Thank you. Thanks, everyone. I think with that, Mr. Chairman, we'll turn it back to you.
All right. Thank you. Any comments or questions from the board or?
So Danielle, can you talk to me about 9 and 11? And I'm watching those trend lines grow. What does that mean for you and your departments?
You know, it means an increase in community need, which I think means some strategic growth from our end. So it is very clear that there is no need, there is certainly a demonstrated need out there for MnChoices and for case management. So I think that makes me extra proud to see some of those successes that these teams have had with consumer satisfaction. Work has never been more difficult, but they continue to grow in, I think, making sure people have what they need. It also does, though, mean that we have to think about different ways of doing business or growing areas of our business where we're just going to have to provide that response with MnChoices, with adult protection, with those case management cases where it's going to make sense for us to hold them internally. we are just trying to watch those trend lines and see what continues to grow and how we can support meeting those needs.
Have you done a per case study, like, as I look at the min choices and, the 2 staff, and it clearly made a difference, and then we had some folks off, but we're not hitting it again in 20 and 21 pretty clearly. Have we done that, and what the capacity is to take a look at from a workforce planning standpoint and work with Lori at what does that mean in those areas, along with, like you say, some technology improvements or whatever else it is? Have we done any of that project out 5 years?
We have not yet projected 5 years, I think, because we have a lot of question marks out there. But these guys do an excellent job at reporting, and specifically reporting their time and how it is spent. Tell from a manager standpoint what these guys do in every 15-minute increment, so we can figure out how many hours it took for each individual that they assessed, what's the average assessment time. But there are some changes to that recently, right? We don't yet know the full impacts of COVID-19 and the state waivers that they will have. So will they continue to have the amount of saved drive time that they have now? Will people still make the same choices? Right now, we've got a lot of people saying, I'd love for you to do my assessment, but I'd like to do it virtually and from home. That would create some more time. So I think we've got a good data set to help inform future practices, but there are just a lot of unknowns yet.
Thank you.
Yeah, I do. Thank you, Mr. Chair. Thank you, panel. This is all really important work and foundational of what we do. I just would like a clarification on page 14, and this is for me, but I think for all of us to understand what it means to live in home and community. I think we have a lot of maybe citizens and residents who think, well, if a person with a disability lives in a group home, they're living in an institution. But my understanding would be this home and community, that includes group homes and other community-based residences. So can somebody just define what it means to be in home community versus being in an institution, and what are the institutions that are left for these folks?
So you are correct, Commissioner Brecky, in that a group home would not be what we would consider an institution. That is considered a community living residence. The institutions that this slide would be reflective of are nursing facilities and ICFDDs, which is an intermediate care facility for someone living with a developmental disability, as well as hospitals.
Great, thank you.
Yep.
And then, I thought I had one more thing. I know I jumped in before. I think it's great, where we started with talking about the proportion of population for one mental health professional. I just think that's really positive that we have more private entities, private businesses setting up shop to provide these services here in Scott County. And then back to Steve had a question early on, like, wow, we still have an awful lot of people per one professional in Scott County compared to the whole state. But I think this is a case where we got to consider where we are too. And I think of a lot of folks who live at Savage or Shakopee or Prior Lake, they, just like with all of our healthcare needs, they may be accessing these sort of professionals in Hennepin County that has a much higher amount, or Ramsey County, that type of thing. So I think this is an example of good data. We want to see that trend increasing, but it doesn't pain me too much that our number of professionals per person or per population is less than the state, just because of some geographic factors there. So, but otherwise, thanks for the presentation.
All right, any additional comments or questions? Thank you very much. Thank you for.
Thank you.